choice. If you are listening to us through Facebook, you will hear the Spanish transmission, and in YouTube, you will hear the English version. So we have all of these platforms in order to be able to be connected and to be together in this important talk and discussion that we have organized for today. Without further ado, I would like to ask Dr. Santa Cruz to take the floor on behalf of ALAFEM. Dr. Santa Cruz. Many, many thanks. Good morning. I hope you are having a nice day. As was mentioned a while ago, the Union of Latinoamericana and Caribean Universities, in coordination with the Latinoamericana Association of Medical Schools and Faculties and the National University School of Medicine, we have all organized this series of sessions whose only purpose is to share ideas around central topics, very specific topics that have to do with medical education in the region and worldwide. Our session today becomes very important because we are addressing a topic that represents a true challenge for all the schools who are training health sciences professionals, and particularly it's important for medical education. We're addressing medical education in clinical settings in the clinical areas where we are training professionals. And this represents a particular challenge. This time we're going to have a global challenge or a vision that goes beyond the Latin American region, because we will enrich our vision with the opinions of a speaker from the European Union, from Spain, from the southern part of Spain, from Córdoba University. And this will be complemented with two other approaches that are a bit different. The same activity, but under different settings and addressing specific problems. One of the other speakers is from the United States, and Dr. Limon from Mexico City. And as moderator, we will have someone who has worked for many, many years on the topic of health professionals training. I'm referring to Dr. Jose Francisco Garcia. He's not only a friend of ALAFEM and the National University School of Medicine. He's the regional advisor and continental advisor for the Americas around healthcare worker and health professionals training. So Dr. Garcia has a very, very broad vision as a part of the PAHO staff, and being a part of the regional PAHO office in Washington, his role goes beyond this because he's from Spain. He has worked at the Andalusian Public Health School, which is very dear to us. Some of us studied there, were trained there. So let me give the floor to Dr. Garcia, who will moderate the session. I'm sure this will be very successful. Dr. Garcia, you have the floor. Good morning, everyone. Many, many thanks, Javier, for this presentation. I think that most important is to discuss this topic and be able to have a very useful, fruitful discussion that can let us envision the future around this topic. I think that the best way to proceed is for me to now introduce the speakers. Each of the speakers will speak for around 15 to 20 minutes. They will share their experience with us. And after that, we'll have time for the Q&A session. I encourage the audience to send their questions as soon as they get them, as they have them. You can use the chats that we have available through Facebook, YouTube, or Zoom. We're going to get your questions and read them out loud at the end. Let me first of all introduce Dr. Sanjay Desai, who is head of the Osler Medical Residency. He's Vice President of Education as well as Professor of Medicine at Johns Hopkins University in the United States. After him, we will hear from Dr. Luis Jimenez Reina, who is the Dean of the Medical School and Nursing School at Córdoba University in Spain. he will speak about the return to the clinical setting after the health emergency. And last but not least, Dr. Ana Elena Limon, who is pediatrician. He has the Specialty Central South Hospital, member of the Mexican Academy of Pediatrics, head of the Pediatrics Board, and Secretary for Social Services at the National University School of Medicine. After the presentations, we will have time to entertain questions from all of you. Without further ado, Dr. Sanjay Desai, you have the floor. Go ahead.
Thank you very much. It's an honor to be here. I wish I were there in person, but one of the benefits of this pandemic is that we can gather like this. I'm going to speak about medical education in the clinical setting and how we've approached it. So I'm at Johns Hopkins University, and I'm the director of the internal medicine residency program. In the setting of the COVID pandemic, we organized across all of our training programs how to try to achieve this goal that all of us really feel is so much a priority. So we, just to give you context, have over 2,000 trainees here, not just in medicine, but if you look at all of our departments, as well as our fellowships, that had to adapt and learn how to educate in this new clinical world. So I'll share, and I'm excited to share some of the lessons that we learned. So next slide, please. I have no disclosures. Next slide. The next 15 minutes is to learn how to not just maintain, but I think we have found opportunities to enhance medical education during the pandemic. And then finally, how to sustain engagement with our trainees during this, which I think is going to take even more work and brainstorming than we've already done. Next slide. And these are the content that I'll share with you. So the first two are actually fairly quick that I'll go through, is just how to engage our trainees and ensure that they understand this new paradigm in which we all exercise clinical work and how education is immersed in that. And then talk more about how we've adapted models that all of us have had for decades, and what new models that we've created in the setting of the pandemic that can educate again in the clinical environment. And the final two are unexpected gains. One is around interprofessional education that we've focused on before, but we're never able to really leverage the way that we could with COVID. And then finally, I think a really important one in the setting of all that we are going through is how to maintain the morale and well-being while we educate them. Next slide. So how do we engage our trainees? So this was particularly important, I think, for internal medicine, but really for everyone. And the model that we used was shared sacrifice. So we did not mandate that anyone, we did not offer, I should say, an opportunity for people to not practice medicine and learn in the setting of patients that suffer from COVID-19. Instead, we framed this as shared sacrifice, that we are all, this is our charge as our profession, not within Hopkins, not within the United States, but in this world. And again, it's a privilege. We framed it as a privilege for us to be able to do what we were able to do. And that helped us again in the beginning of this crisis. Next bullet. We educated them in a variety of ways. And so I want to talk about just quickly the roles. So obviously there's the frontline roles where they were at the bedside. And I think that was the most challenging for us to create. And I'll talk about how we constructed that. We found new ways to create education by telemedicine. And so I think everybody did this across the globe. We have been focused on telemedicine, but this COVID pandemic was really an accelerant for us to step into telemedicine and teach new skills that we were unable to teach before. And then finally, we have created new virtual education roles that support the clinical environment. I'll talk about those. Next bullet. Finally, we made a very deliberate point to emphasize and prioritize safety so that people could learn. I think that they wanted to take care of patients, they wanted to learn, but they were worried, as were everybody. There was great unease about what we were all stepping into, knowing the lack of information, not just for themselves, but for the safety of their families. So we did create exceptions based on the data that we were familiar with, related to people, for example, that were pregnant or immunocompromised, to avoid direct frontline care. We ensured continuous conversations around personal protective equipment. We iterated processes every day, at the latest every week, because as we learned how to make sure people were safe and talk about with them, occupational health was a very important focus for us. As people develop symptoms, how do you maintain, how do you avoid depletion of your workforce and allow them to learn again, in an area that they feel safe. And then finally, I'll talk a little bit at the end about communication and transparency, which again, I think we're unable to educate them without making sure that these processes were very clear for everyone. Next slide, please. And then finally, this is I'll go quickly through this part of it, but the reminder of mission. So historically, we always focused on education. In fact, ACGME here in the United States used to call it ACG, service versus education. They've redefined that now to non-physician tasks. But the idea is that we should, for trainees, make sure that we create educational opportunities that are unique and not based just on the clinical enterprise. And here it's different because we have to take care of the patients that arrive to this hospital with COVID-19, and only we could do it. And so it was this reframing and reminder, really, of the mission that all of us have chose to pursue. Next bullet. And this is where I talked about internal medicine. So while there was shared sacrifice across the entire university, across all training programs, I think it was very important to highlight to our medicine trainees in order for them to learn that this is, in fact, an internal medicine disease. And because of that, there were going to be extra obligations and extra needs for them. And that, next bullet, please, that this was not a service, but in fact, it is inseparable. The service in relation to COVID is education. This is new for everyone. How we manage these patients, we will learn from every day, and we will be able to share, disseminate that. And so we are not only caring for patients, but we are learning as we do this. And this is going to be a tribute to. And final bullet is, there's two more here. One is related to, as you guys think about the medical education paradigm that you will use, it's important to accommodate for or consider the trainee density. We have a very large footprint of teaching beds that have teaching footprints on them. What I mean by that is trainees that manage patients. Other hospital systems have many more private physicians. And so again, I think when you have a rich trainee density, these lessons I think are even more important. And final bullet. Last bullet. And the final thing is just that I think this is an approach that we learned from that I wanted to share, which is we overstaffed as much as we could our units so that we could actually create training and education models and then right-size them as we learned how we might do this better. I'll go now to how we did this and the lessons that we learned. Next slide, please. So the first was adapting models that we do every day. So rounds. All of us have bedside round. This is the cornerstone of medical education in the clinical environment. How do we do that in the setting of COVID when we had to limit the number of people in a room? We had to limit the use of PPE. We had to create virtual scenarios and allow people to engage even if they might not be there. So the first thing is we took inventory of what do we currently have that can enable this. And we used cell phones. We used our EMR. So our EMR in many instances have chat functions and opportunities for people to engage in the care without actually being physically present. And then finally, we used the communication platforms that are in our hospitals. So we have devices that nurses wear, that physicians can wear, where you can communicate directly through a badge in real time to people outside of the room. This allowed us to continue to teach with a smaller group of people that were at the bedside. And so this was useful, but was clearly not sufficient. And so if we go, what we had to do was invest in new resources. How do we bring people that were outside of the room into the room? What we invested in were a few things that I think many have also invested in. So different video cameras or webcams, microphones that were actually not just microphones on your phone, but actually professional grade microphones that you could use that have multiple inputs and ability for multiple people to hear at the same time. These were very important, and I think what we learned, and we didn't do this initially, was that we had to have high quality equipment. It was not possible for us to teach on rounds with people outside because they couldn't hear, because the microphone wasn't loud enough, the speakers were not high enough fidelity. We had to create tables or benches that were mobile so you can move these cameras around and identify who in the room is going to manage the cameras. So these are all processes that I think were required to adapt the models that we use now to ensure that people outside could continue to learn and from their room continue to teach. We had our anesthesia colleagues created what looked like someone out of a sci-fi movie of the future, where they would become essentially robotic. They would have a headband on that was mounted an iPhone or a phone of any sort that had a camera. We had a mic that connected to them and Google glasses that you could actually see the Zoom while you're teaching. And this allowed us to round basically with the people outside of the room, not ever entering. Yet they felt like they were at the bedside because you were able to bring them there. Another thing we relied on and we invested in were digital diagnostic equipment. So digital stethoscopes was the one that we used most commonly. And this was very helpful for people outside, again, to learn. And I would say that this was better for us than before, where you're trying to listen and then you have somebody else listen. Everybody was listening at the same time. So it accelerated this opportunity for us to teach actually more effectively in some of these instances. And then finally, we were very deliberate about who really needs to be in the room. And so everybody came in the room. And I think that probably wasn't the right model because it dilutes the educational value while you're there because of the numbers of people in the side conversations. And so we decided that these people have to be in the room. They're essential to the care of the patient. And from there, we will bring people into education, but not physically there. So medical students, other residents on the team, the social workers, the case managers, the pharmacists, they will all teach us, but they would do it virtually. And so this was adaptation of current models. And the second bullet here is about conferences. Please click. We all use conferences like this one, and I think this was another opportunity for us. We were able, through Zoom, just like we are doing at this moment, scale, create distance. So we were engaging people from across the country and across the world in our conferences, and we were creating flexibility where we could do it not just at noon when people were eating lunch, but we could do it in the evening. We could do it earlier in the morning. We were able to create joint conferences with partner hospitals or peer hospitals, and this allowed relationship building that we never had before. It allowed clinical reasoning sessions and joint, and with the breakout rooms that you're able to create that we never able to create as effectively in person. So there were real opportunities related to education, not just at the bedside, but clinical education that we were able to find. And then finally, as I think we're doing here, we're able to use, and I never anticipated, the chat function, which was wonderful for us. So we had so much richer discussion about education than we ever had before in two ways. One is that we saw all of the data and the comments that were coming up. The second is it democratized it. So I had noticed in particular that we had many more questions than we historically had for women than we did when we were in person. And I think the chat function and the ability for people to write allows this democratization of educational participation that we didn't have as equally before. So again, some really big gains from adaptation of current models. And then my second slide is how do we create new models? And so next bullet, the first is just around clinical education. So we used Zoom for rounds, and you can use any virtual platform that I think many people have. This allowed us, again, I think in some ways to be better. We were able to zoom in on certain physical exam findings. We were able to actually have people really listen to the history, even though just one person is taking it because half the people were outside of the room. Telemedicine was probably the biggest area where we grew very, very fast and learned how to communicate. So you have to learn how to communicate through a video camera or even by phone. Sometimes it wasn't just by video camera, but the skills that are required for that are different. And we were able to mentor and shadow people and listen to people so that we can give them feedback on that. And I think if we all predict the future that all of us will be practicing, it will be heavily reliant on telemedicine as well as even just telephonic communication. So those educational skills we could ramp up much faster in COVID. We created opportunities to learn clinical skills for people that were not physically in the hospital. So historically, we only had people on the team learn from those clinical experiences. Because of COVID, we had a set of people that were at home because we were no longer doing elective work, for example, or some other rotations had been canceled. And so we have this group of people at home ready to come in when they might, but they needed to learn. And so we created virtual ICU rotations where they would zoom into ICU rounds. They would listen, they would learn, they would get the lectures, they would round, but they would actually contribute. And so there were many parts of just work, medicine on the floors as well as in the ICUs that require somebody in the EMR to do medicine reconciliation, for example, or to start the discharge paperwork, or to do some of the work that's related and really hard to do while you're learning and caring for the patient in person. And this is what we were able to do by leveraging those at home who not only help, but then were able to learn. And then finally, communication with families and consultants. We couldn't have them visit, and we had to learn very quickly how to effectively communicate everything we wanted to by either Zoom or by phone. Next bullet. And then finally, as we've talked about already, didactic education conferences I've talked about, large, diverse, much like this. We were able to also rely much more heavily on social media and podcasts. We created curricula and educational sessions on how to create tutorials, for example, which is in Twitter, how to create podcasts. We've launched 2 that have become very popular in internal medicine. Because again, many people are learning this way, but it also creates community. And I think that's another benefit that we learned, how to teach clinically, but really teaching for what we think we'll be learning in the future, how we'll be learning in the future. And then finally, visiting lectureships. So it was difficult before to bring people in because the expense and the logistics, and now we're able to do that much more easily. So we get access to people from around the world that I think we didn't have before for clinical education. Next slide. And I wanted to talk briefly about interprofessional. So we worked hard on creating interprofessional relationships. However, COVID taught us more than anything how we must work across silos. This is not just physician to physician between medicine and surgery and anesthesia, but this is across all functions in the hospital, which we traditionally live in silos, and we were able to break down because of COVID and learn from one another. And I'll give a couple of examples. Next bullet, please. One was that I used the word democratize again. It just evened out the fact that we were all mission minded. We were all there for the same reason. Every team and every person on the staff was the same. So there was a new equivalence between those that were caring for the patient as a physician, those that were there cleaning that room as somebody that sanitizes the room. This was different, and it felt as if why were we not having the same relationships and respect for one another before. But quickly we learned that we are all taking the same risks, and we all have an invaluable value to provide to these patients. And so we were able to communication and learn from one another very differently. And some of those professionals you learn from that you didn't learn from before, respiratory therapy would be an easy example. Hospital epidemiology, infection control would be another example. Next bullet, please. Cross-training. So we took time, knowing that we didn't know how big this surge was going to be, to make sure that we staff allowed us to properly manage the patients that we had. So, for example, in our ICUs, we brought in plastic surgeons, dermatologists, radiation oncologists, and we brought them before we needed them. And this allowed us to ensure that they get ramped up a little bit for if we need them in a surge, but more importantly, we learn from them. So when we had an ENT resident with us, we were able to manage the ET tubes for our patients with COVID much better and much more effectively than we were without them. We learned things about procedures from our surgeons, surgical colleagues that we hadn't learned before, so it enhanced education. Next bullet. And then I mentioned this already, but the loss of hierarchy across everybody in the team creates a learning climate that is much more safe and enjoyable for all. And I'll go quickly through my last set here. Next bullet. Everybody, next bullet, please. Actually, there's phases of crisis, and I'm going to close on this, and it's about morale and well-being. But I think you've seen probably a slide similar to this before, where there's this heroic stage at the beginning, and then this honeymoon, and then disillusionment. And I think we thought about this a lot. Next slide. And you can hit all the bullets so that they all come up, and this is the slide I'm closing on. So this is really important. We reflected on how do you create sustainability, and we learned that you cannot have people be in a learning mode without feeling safe. So we created community with food and water, team break rooms, communication that was very different, ensured that the institution and us created opportunities for rest. My main focus and point here is that this was very deliberate, and I think without this, we would not be able to educate our residents in the clinical environment unless we first look after their health and their safety. And then my last slide I just want to share with everyone is when this is last year when I was visiting and flew into Mexico City, and I want to thank you all for having me. And I welcome any questions at the end of the session.
Many thanks, Sanjay. Fabulous presentation. Muchísimas gracias. Una presentación muy interesante.
Thank you very much. This was an extremely interesting presentation. We will proceed with Dr. Luis Jimenez from Córdoba University School of Medicine and Nursing. Thank you very much, Dr. Garcia. First of all, I would like to thank the Union of Latin American and Caribbean Universities, the National University of Mexico, the School of Medicine, and Dr. Fajardo, Dr. Santa Cruz, and thank you very much, Dr. Garcia, for being our moderator. I would like to share with you my presentation on what is it that we have done And what did we do at this time of crisis? As Dr. Desai said, when we encountered this crisis, what did we do then and what are we doing now? On the screen, I'm showing you the chart, the confirmed COVID-19 cases at Cordoba Hospital, which is the major hospital training medical students. As we can see, when we were around March 20, we started seeing the peaks of the number of cases that was ever increasing. As a result of this, our hospital situation changed drastically, and we had to drastically change our activities. We're going to analyze what we did during the first peak. This taught us the things that we should not do, and at least in Spain, we are about to face the second peak. I'm sure that this chart is similar to one that we would have country for all of Spain, but I wanted to show you what happened at the major hospital for the training of medical students here. The first surprise was on March 3 in Spain. From the administrative standpoint, we have a central Spain, but we have autonomous communities like Cordoba and Andalusia, and they are the ones who regulate our activities. We received this notice from the health service and the family medicine service saying that on March 3 of 2020, all education activities that for undergraduates or any other type of teaching activities or education activities for medical students were stopped. They had to stop. So they were left without education. There was no way to provide education to them. At this moment, they still allow them to continue to provide classes in the classroom at the university. They could continue with the different workshops, with the simulation classes and the clinical decision making. All of those activities could continue. This took place at the university, but this was a true surprise because overnight we were told that clinical students could not continue with their activities. This was terrible for us because at that point our capability of response was just to be surprised because our students were not in contact with the training setting anymore. And we didn't think about other alternatives. Of course, we started thinking about video conferencing and virtual media. After that, we started receiving more and more regulations, trying to adapt our clinical situation to what was going on. We had different notices about quality, about the education ministry. There were different documents that we received where people were trying to adapt the things and the regulations to what was going on. There was a series of regulatory controls that were imposed on us so that we could adapt to the situation. But these were immediate reactions to something that occurred in a traumatic way, I would say. On March 14, in Spain, the lockdown was established in Spain. This was a very complex process in Spain. We were one of the countries in the UA that experienced the most severe lockdown. From that moment on, we, the professors at the medical schools, had to reinvent ourselves. Of course, we already had certain virtual platforms that we had already been using, but we were forced to use them only exclusively. We were able to continue online most of our education activities. At that moment, this represented a very important resource to rethink what we should do. I'm referring to one of the documents, the regulatory documents that we received, within the framework of our university, it was said that we would address all the recommendations. They will comply with the recommendations coming from the directives or the heads of the different medical specialties. They said around March 14 that all the students who had completed more than 50% of the on-site clinical training with patients during their respective courses, that they could complete so that their clinical and academic training could be recognized. They could complement that with other activities that were complementary. For instance, clinical work, and we are fortunate to have a university that has very good means for this. So we decided to use the virtual platforms that we had already been using. Also on March 14, at that moment, our School of Medicine and Nursing, though the students who were about to graduate had completed 72% of their training. They had completed from 72% to 81%. So we felt comfortable with this because this allowed us to have the proper outcomes so that the academic authorities could recognize all of these students. This was all clear for us, but I think that this was clear for us at our School of Medicine and Nursing. But throughout Spain, they asked whether the accreditation and the clinical training that we had provided during this traumatic stage was the right one or not. We were using a tool that we had started using since 2013, 2014, which is the ECOE test. This is an objective clinically structured exam that we had used, that had been used by all of the schools of medicine in Spain. Of course, that we had to adapt it to the virtual setting. As a result of this, the Directorate of Schools of Medicine of Spain established a series of initiatives to adapt this exam, accrediting the clinical training of the students that were trained during the pandemic, so that they could take the exam without being on site. And the decision was made by the committee of this exam on March 25 of 2020 that we had to prepare an exam that could be affordable and that should be available through the different platforms that all universities were using throughout Spain. We're fortunate to have a virtual common platform like Sakai, Balboa, and others that our students are used to using on a daily basis. Using those platforms, we had to design the kind of exam that could be taken through the platform so that we could accredit our students. This was a very important decision. So as of March 25th, Dr. Santa Cruz said, we spent a lot of time doing this. We're spending a lot of time in front of the screen, in front of a display doing education. Well, we have thousands and thousands of students who have taken the exam. We held a lot of lectures, conferences, trying to have a common platform for this exam. I show you on the screen the different schools of medicine in Spain and the different platforms that they use. There is a script platform that was provided by an external provider. These are the universities that use the script platform: Zaragoza, Europea, Francisco de Vitoria, International de Catalunya, and Cardenal Herrera Oria. This platform was used and was tested to see whether that was 654 students of the different medical schools in Spain participated in this test. Another modality that was used by 16 medical schools with 2,664 students was what you see on the slide. Each university used their virtual platform. Most of them was Almuden. Moodle was the main one used. Others used the Sakai platform. All of these platforms were used to apply that exam. 3,011 students at the same time using each their own platform, using a uniform system for all. And they performed that. They took the exam so that either June 6th or June 20th, those same students could take the exam to determine whether the clinical skills that they had learned were appropriate and were in agreement with the previous experience that we had from 2013 and 2014. This is the competency map, which was fundamental. From the very beginning, we took this into account. This is a competency map that we had from 2012, where we started to work with the changes that were made in 2018 to adapt this map. Because we asked, what is it that we wanted to assess out of the students' clinical training in order to know whether they had learned the right things. This is the competency map that includes anamnesis, clinical exam, technical and procedure-related skills, communication skills, etc. This is the model that was also reproduced virtually in the virtual platform.
5 minutos.
Perfecto.
You have 5 minutes. With what we had learned before, we determined that the response was in agreement with what we had taught. So we decided that the response or the answers were right. However, we had learned that this was not the best way to teach our students. However, we were working within a contingency. Look at the chart where I'm showing the second peak. You may be asking, second peak? Yes, we at this moment in Spain, we are thinking that we're going to experience something similar to what we experienced in the first peak. What are the measures adopted in view of COVID-19? We held an extraordinary meeting on September 19, and we have tried to adapt everything to our reality. This is our reality. The students participating in clinical courses, all of the large group activities, the on-site and theoretical activities are held through video conferencing through our virtual platform. They are held virtually. The rest of the activities of medium-sized groups like workshops, seminars, simulation, clinical decision-making, all of them using the personal protective measures are held on-site. Small group activities for many of the subjects that we teach in years 3 and 4. That is to say, the activities that required being at the hospital for 8 to 10 days, they were canceled. But in exchange for the clinical practices are being held during the rotation from September 9 all the way to May 30. This period is spent at the hospital in exchange, but in exchange of this on-site activity, we had to cancel the small group activities for specific subjects. As Dr. Desai has said, our students are not in contact with COVID patients. They are not part of the COVID care. Through the video conferencing or the cameras that we have at the hospital, they can watch. The rest of the activities, surgery, specialties, all of that is open for all of our students, but not COVID care. But of course, when patients are coming to practice at the hospital, they need to be aware of the different protocols. They need to undergo a serologic coronavirus test and follow their respective protocol. And they need to fill out the questionnaires about their contacts, about their symptoms. this serves as a learning experience for them, so that and we make sure that when they come back or start practicing at the hospital, they know what the protocols are. Our clinical activities have been recovered. Our students are at the hospitals and the healthcare sectors, with the exception of what we call the COVID circuit, where they can watch through video conferencing. Obviously, we have that the students learn that they need to meet a series of requirements. They need to fill out documents. All of this serves as a learning experience so that they know how these COVID circuits work inside the hospital, even though they are not directly involved in them. I think this summarizes everything, but most of all, I would like to say that the National Conference of Medical School Deans has determined that now that students are back at hospitals and at clinical activities, a requirement is the COVID serologic test, and that our activities have to be adapted to circumstances. If our students are going to be practicing at the hospital, they will be excluded from the COVID circuits, and we need still to determine whether the clinical training was right or not. Based on this, the European Union determines whether the healthcare professionals have met all of their requirements, and they need to confirm if what the students have done during the pandemic is correct. I will end with this. I don't know if I've exceeded my time. Thank you very much. Thank you, Dr. Jimenez. Congratulations for what you have done. I'm also Spanish, but I really want to congratulate you for what you have done, because you have reached a common position and a consensus among all of the heads of the medical schools. That's incredible. Yes, that's one of the things that we are most proud of. Thank you very much. We will now proceed with Dr. Ana Limon. You have the floor. Good morning, everyone. I would like to thank UNAM School of Medicine, ALAFEM, UDUAL, Dr. Santa Cruz, Dr. Garcia. Thank you so much for this invitation. I will speak about medical training in clinical fields during the health emergency. The Clinical Education Secretariat that coordinates the last 4 years of medical school, this is what we do. In the third year, we have 2,681 students. In the fourth year, 999. In the fifth year, which is the internship, 1,055 students. And in social service, we have 918 students. As you can see, this is a world in itself. We have 5,653 students in the clinical area, with 3,057 professors, 180 venues and sub-venues. Most of them pertain to the Social Security Institute, to este, and we also have National Health Institute, Pemex Hospital, Mexican Red Cross, and the Mexico City Hospital, besides a couple of private hospitals like Medica Sur, ABC Medical Center, and other smaller ones that help our students be there. We started later than you because the pandemic hit us a bit later. As of March 17, third and fourth year students were taken off the venues where they were working, and they were sent home. On April 7, the physicians were doing the internship were suspended. Their activities were canceled because there were outbreaks at their hospitals. We didn't have properly established protocols, so we decided to take them out of all hospitals. 918 graduates remained at their venues. They have continued to work there. We've been close to them, but they have continued to work at the hospitals. What did we do for this purpose? Well, we had to reinvent ourselves. Also, we created support programs for students, providing training to interns and graduates. We created a platform where you can find different types of materials, different media for training on COVID-19.
Las cosas particulares que emergen durante su labor asistencial.
We oversee the different particularities that emerge during their care activities. We wanted them to have the proper information that we took out from healthcare institutions, WHO, our medical school, and periodic updates that we received on COVID-19. We did monitoring of the students' health status, and we provided advisory to minimize the risk conditions, and we focused on the residencies. We offered several courses about the detection, prevention, response, and control of COVID-19. We use different educational means to disseminate this information so that they could learn under less risk. Training programs on COVID-19 infection. Well, the Ministry of Health has a course called EduCats. It's a very good one. It's available in their platform, and the students took this course. And the University Commission for Care of COVID-19 provided specialized care. All of this was on prevention of COVID-19. This is another platform available at the Social Security Institute. You're looking at pictures of the different support programs that we established for the physicians. We trained 919 interns in a hybrid way. We had a specific program in which students would attend the university, of course, with all of the personal protective equipment and with social distancing. They were taught how to use PPE when caring for a patient suspected of having COVID-19. They also took an online course. I'm sure they learned a great deal during this course. Graduates took other courses on prevention, primary health care, emerging viruses, detection methods. All of these courses were taken through video conferencing at their own home, at their home. We knew that there were a lot of mental health problems. So we decided, together with the psychiatry and mental health department at our School of Medicine, created a psychology course to support and the students for stress management purposes. They took a course on how to disclose bad news, and they underwent a mental health assessment. These are the support programs for students. They were conducted through the Moodle platform. All physicians and pedagogists who are part of the Ministry of Health, they all work together so that if there was a professor that for some reason could not give a class because of he was sick or had a problem, that they had supported material. They created 497 clinical cases of the topics that were scheduled for third, fourth, and fifth year. In fifth year, they have 6 modules. They prepared 125 PowerPoint presentations for topic review, 144 tutorial videos with classes of their professors on multimedia, 386 repetition articles, review articles, and reference material was prepared. 72% of the students have logged in the platform in order to have access to these programs. We hope that many more will use it. I'm showing you here the various things that we did to approach our students. We created a web page for each of the years of medical school. This allowed us to be close to the professors and to the students. We included information of the authorities of the medical school, training, and other kinds of assessments and information. We updated them on the academic situation. We gave them information on the contact to have permanent communication, the different courses that were offered for training and for the hiring of professors. We provide dynamic information about the situation at the different clinical sites. This has been extremely useful for both the professors and the students. We also designed a web page for each of the clinical year, as I said before. Each student with their enrollment number or their ID number can have access to their webpage of their year. They can see what are their grades, what are the courses provided, what are the resources that are available, the free of charge video conferences, and they have access to the different surveys. This is a web page where we have posted all of the ads and the information about the non-clinical subjects. For instance, pharmacology, bioethics, history and philosophy, anthropology, history, bioethics, so that the students can follow them and to facilitate their access. Permanent communication, in my view, is most valuable because if we are concerned, imagine how concerned and how anxious they are, the students. So we use all electronic media, email, WhatsApp, Facebook, etc., to communicate with the students. We have had collective communication, individual communication, communication with the heads of the groups, with our director of our medical school, with Dr. Fajardo, Dr. Durante. So this way we have been able to address their concerns, those that we can. If we can't address something, well, we tell them that we are with them and we are trying to help them. We have received 640 WhatsApp messages. I think that's too little, but there are other means of communication. In view of the needs resulting from the pandemic and the lack of information that we had, most of all initially, we established a call center that started that was launched on April 13th. It still works. It's a call center and a chat center. This was done by 63 that received courses. They received updates. They receive psychological support and everything they need so that they can be in charge of the call center and take the calls of the people requiring assistance. We have received calls from throughout the country, not only from Mexico City, but from the entire country. We have addressed more than 10,000 requests for information. We have supported graduate physicians throughout the Mexican Republic. We need to remember that graduates in their last year, they do the social service and they need a lot of basic equipment. This is important. The support has been very important because these are physicians working in remote communities, in rural areas, and providing them with all of these kits. We have been able to assist them importantly. We have trained the professors on the information and communication technologies. We have Meditic, which is one of the tools we use for this purpose, which is for online teaching. YED, which is a model teaching how to create online courses. And we have the master program for distance teaching strategies. This represents a challenge because we have more than 3,000 professors in the clinical area that are in their clinical venues. It is expected that we will have a trickle down or a cascade effect, and that we will have more and more people that we will be able to provide information to. We've had about 14 virtual classrooms by the Secretariat. We are providing guidance to professors in instructional design and content design. 100% of professors have had to migrate to distance education, and they assist students of clinical subjects. All students are working on their clinical subjects. 97% of the students do have a computer, a tablet, or a smartphone. What happens with the 3%? We have asked some of the academicians how did they do it. They don't have a computer, the 3% of them who do not have a device. Well, they say that they share someone else's, that someone else lends them a tablet or a smartphone. And we found that 87% of them have a stable internet connection. 94% of pre-graduate interns between May 7 and 17 went back to their clinical venues, or they have went to other venues that were classified as non-COVID. But we are asking, what are we going to do with the 3,680 students of third and fourth year? We hope they can return their on-site activities once this is allowed by each of the institutions. What is the health status? From March to now, we have had 84 cases among our students. 2 of them died. We have done tests. 4 of the professors died. One of the students died due to COVID that he acquired outside of the school, and another one due to a motorcycle accident. 4 professors have died. Many of them have been infected, but they have done well. We want the students to come back with the necessary PPE in a staged way, little by little. Health represents the major possession. Happiness is the greatest treasure, and trust is our best friend. From Lao Tzu, thanks for your attention. Let me end my presentation here. We are right on time. It's 11 a.m. sharp, so it's exactly, we are doing perfectly well time-wise. Thanks to all 3 speakers. Thank you for your excellent presentations. We have several questions that I'm going to ask to all panelists. If you agree, I'm going to ask a first question, and any of you can answer because the questions are not addressed to anyone in particular. I would like to encourage those who have any questions to please ask them through chat or send them through Facebook or YouTube. We will have a discussion for the next 15 to 20 minutes, and I will close later. The first question that I received comes from Dr. Rocio Gomez Lopez. It's not addressed to Dr. Desai, but I think it's important for all of the panelists to try to answer the question. What is your opinion about the strategies for the use of telemedicine at public hospitals in a country where there is no internet access? This takes us to asking, how would you solve the problem elsewhere? that problem elsewhere, even if you don't have this problem in your country. What are the different strategies available? Because at some point in time, I'm sure that you have faced the lack of media. What are the strategies that you have followed, let's say, to convince your authorities about the need to invest in technology and to have better management and better availability of internet? Dr. Desai, would you like to start answering?
Sure, I can start. And I think it is relevant for us here as well. And I think there may be a perception it may not be as much. And there's two reasons. One is that there are pockets, certainly in many of our cities, Baltimore is one of them, where there are patients that do not have access to this technology. The second is it's become so increasingly urgent for us given school for our children. And so that has the same implications in terms of access to broadband and to internet. And so I think there are a few strategies that we've thought about. One is, like many things in most governments, it's driven by money. And one thing that we're able to advocate for in order to do this is to allow for billing, at least in the United States. Until COVID, we were not able to actually bill sufficiently for telemedicine visitations. Obviously, we had to do it during COVID, and so our government changed the rules that you could create billing for this, and that prompted a lot of power and advocacy around making sure that patients have access to this, because it ultimately led to reimbursements for hospitals. So hospitals themselves were investing in these technologies for patients because in the end it helped them retrieve the money that they also wanted. We have pilot programs where we've given iPads to patients as loans, and they would use them and then bring them back. And then secondly, the other point I would make is that this is driven by the school systems, that because our children need access to broadband, that there have been many governments as well as companies that have set up hotspots around the cities in public spaces like parking lots. And that has become a resource for those that don't have access to this in their homes.
Muchísimas gracias, Dr. Jiménez.
Thank you very much, Dr. Jiménez. I have two questions. What about the IT support for the students? Spain is a country with a lot of debts, but we are part of the European Union, and there is a series of funds that have been given to the different countries. But anyway, we already had the necessary means so that most of our students could have, at least at the college level, could have IT resources. And those who did not have them, and this is the case of Córdoba University, they have offered them as loans, and they have also offered them what is colloquially the hotspots, allowing people to connect to the internet free of charge. At times, some of the students had to go to the municipal offices trying to use their IT resources. But all of this has been possible thanks to the fact that most of the students already had the resources prior to COVID-19, and those who didn't have them, well, the university offered them to the students. Regarding patients and healthcare, fortunately, the public healthcare network in Spain is quite good. The Spanish healthcare system, as all of you know, is quite good. And so they are providing daily care with taking other precautions with all the patients that present. But we are also providing telephone consultations to the patients for those cases that cannot be addressed through the telephone. Then patients get an appointment to come to the healthcare centers with all of the precautions. Of course, that if we read the news, we know that there is saturation in some of the healthcare centers. But the truth is that the system is working. At times we ask from it more than we can get, but fortunately, with the means that we have available, education has been possible and healthcare is being possible as well. Dr. Limon, sadly enough, we are not in the European Union. Our situation is much more different. In Mexico City, we have several hotspots that provide access to internet. Not all of our hospitals have a proper internet connection, but we are working on it. The pandemic has forced the government to provide more hotspots. The next question comes from Dr. Cynthia Sanchez, who is professor at the third year of clinical education. She would like to know whether you can share with us some of the tools that you have used that are safe when one is performing assessments and virtual exams. Yes, I will gladly share them with you. You can contact me or you can contact anyone at the secretariat. We have started to do this more and more. This is difficult because the exams are taken at home. We've seen that they take pictures so that they take longer because they are looking for the right answer. This hasn't been worked as well as we expected, but we are doing better and better. The university does have a team that is doing this. Dr. Desai, what are the tools that you use for assessment?
That answer, because we were also struggling with this, and one thing we started to do was we are doing virtual examinations with patients in the next room to see what we can learn, and then we will go and examine them physically and see what we missed. And then we're iterating that to try to learn better. How do we ask the specific question so that we wouldn't have missed this next time? So we're trying to learn how to do this better when we even have them here in person. And I'm sorry, I didn't hear the question.
All right, sir. Dr. Jimenez?
Dr. Jimenez, what are your suggestions? During the National Conference of School of Medicine Deans, when they proposed that students take the exam at home, this led to an initial debate about something that worries all. We have an institution that is the Estancia University in Spain. This university has a 40 years experience. Distance University told us that there is no method to make sure that the students don't use what they should not be using when they are not in the presence of a professor or someone or supervisor. This year we have said that we're going to have a test in the IT rooms. Unfortunately, all of the Spanish universities have these rooms. These would be tests using IT media, but on-site tests. They would have to come to the university because even with video conferencing control, we have legal problems of students that argue that they are attempting against their data protection and data privacy. In the EU, it's difficult for us to visualize their address. So when the exam is done, legally, not everything is covered. So in our case, when we have the common exam, we will try to use the means that we have available. We're going to use the IT room at each university that has enough room for many students with a professor that will supervise so that the tests are taken online, but they have to be there on site with under the supervision of a professor. We get a question that says, how have you thought that postgraduate students will go back to the surgical specialties? If you allow me, I would like to answer the question. In Spain, the postgraduate training takes place outside of the university. As Dr. Garcia knows, in Spain, once the graduates graduate from the medical school or nursing school, they have to pass an exam. This is a common exam for the entire country, where graduates, according to the score, can have access to the residency positions that are available in the country. The graduates are doing their specialty training within hospitals, and they have remained at the hospitals. In Spain, the residents have continued to work. There has been greater control at COVID circuits, or more or less participation of residents in COVID circuits, but they have continued to be there. Dr. Desai, would you like to answer?
It's a similar answer. We have had very few residents who have had prolonged absences because of COVID, and those that have, if it violates any of our accreditation rules, there have been accommodations generally made so that they can finish on time.
Doctor Alemán?
Sí, aquí en ningún momento han salido de los hospitales los residentes.
Our residents have not come out of the hospitals, surgery residents, and they have been working on with COVID patients rather than what they were supposed to learn. The next question comes from Ms. Aguilar. What about the use of cameras for the rounds or the education activities? Do you have any process or any consent process for the patients to allow for cameras to be used? Well, usually in Mexico, we need the consent of the patient. Yes, we have the patient sign an informed consent. We use the informed consent, but for surgical activities in the OR, for the rounds and the usual visits, we are not using cameras for this purpose. This is basically for surgical activities. This is when we bring with the camera the image outside of the OR. This is when we ask for the patient's consent.
Similar, we are not using it for rounds. We don't require consent for rounds. We consider this just the same as rounds before, but extended. There's no recording. It's used on a HIPAA-compliant platform within the hospital. If it's ever used to be shared, then we would ask for consent.
Las preguntas que están llegando ahora, hemos pasado de cosas muy generales a cosas muy concretas.
We're starting to get much more specific questions. We've gone from general questions to specific questions. Someone asked whether the presentation would be available and whether we could provide the emails of the speakers. I imagine that both the UNAM and the organizers have arranged for this. I'm sure that you'll be able to share the PowerPoints and the emails of the panelists. I have one last round of questions with one question for each one of you. Dr. Jimenez, this question is for you. They congratulate you and thank you for your presentation. From Mr. Hernandez. Have you carried out an analysis about the validity and or reliability of what you're doing? Yes, we have of the ECHO exam. Yes, we do have a national coordinator at Complutense University in Madrid, Dr. Garcia Sewane. He has done statistical studies. Yes, he has done the full study about reliability and consistency of our exam. This has already been done. An assessment, this is available. I don't know if this is public or not, but we do have available the results that our professor has shared with us. He has been responsible for making the assessment of the ECHO exam. One last question for all three of you. What has been the reaction of professors and what are the strategies that they have followed to teach management of technology? What has been your experience with the professors? This is one last question.
I can start. I think we have had full spectrum, bell curve of everyone. Those that are very technologically adept and we use them as super users and they teach others, and those that are in the middle that are easy to train, and then others that we had to really bring along. So we created faculty development seminars that were videotaped and that were shared with everyone on how to use these technologies.
Doctora Limón, Porque es que el doctor Sangay con la traducción está...
Dr. Limon, go ahead. Yes, as Dr. Desai said, the youngest people are the ones who are more familiar with technology, of course. It's very easy for them. For the older one, it has been more difficult, but we have an area at our School of Medicine that assists people. Many of them have created their own virtual classrooms. It has been very difficult for some, less difficult for others, but we have 100% of our professors who have gone virtual. As to Spain, fortunately, Spanish universities have worked for many years using virtual platforms. But in the end, I fully agree with what Dr. Desai said. So who were already very technology have benefited a lot from this. And those who didn't use much technology have been reluctant. I think that this has simply shown each one's situation prior to the pandemic. But fortunately, Spain, both professors and students were somehow trained in the use of virtual platforms, so things have run quite well. Thank you very, very much. Thanks to all of you. Thanks for your presentations that have been excellent. I would like to honor your presentations with this last summary or my final remarks. I've tried to summarize this in only 5 words. These are the takeaway points or the take-home messages for you. Under the topic, considering the topic of our meeting, which is how to return to clinical education, I think that the merging of education and service is extremely important. We have had to handle this under an emergency situation. We know that there are many things that will change, the formats will change, but we may say that the clinical practice with patients and directly, we need to try to find the way for this to occur. From the standpoint of medical education, we can balance the number of hours, the number of patients, but this will continue to be essential. Out of the results of these presentations and those that I've had the opportunity to hear in other countries and continents, what does exist is available, but this has confirmed that there is a huge heterogeneity around the management of this topic and other topics. Within the countries and amongst the countries, because all of this derives from the specific situation of each country and each region regarding their legislation and other things. This has become evident if we compare what has happened in Spain and in the United States or Mexico. Second, an essential point that continues to be of the utmost importance when we think about returning to the clinical venues is safety. This is extremely important, but we have to consider that what the 3 experiences that have been shared today is not exactly the same as or what prevails in all of the schools of medicine, because at times there is lack of PPE for some professionals. Number 3, IT technologies, we already had them, we were using them, but they're here to stay. Those who do have them are learning much more. Those who didn't have them, well, they are working very, very hard in trying to establish them. There is a very evident digital divide, digital gap, and we have data from UNICEF and from other organizations that show that more than 50% of students in the Americas region, including all of us in the Americas, do not have enough access to the internet so as to continue with their education. This will lead to acquiring many more skills. We've heard some examples from Johns Hopkins, from UNAM in Mexico, and from Córdoba University about what imagination and inventivity can do if we want to make the best use of what we have available. One of the messages of Dr. Desai was that it's important to invest in quality technologies. There's no use in improvising. If you have good cameras and good microphones, you will be able to make much better use of that, and you will have a much better result if you have the students learning outside of the room. And this point is that of evaluations. I thank Dr. Jimenez because he presented to us the topic of the the exam that they are using in Spain. Had the pandemic not reached us in Spain or in other countries, well, of course, this would have been delayed and we would not have tried to have virtual exams or virtual evaluations. And of course, this is going to have an impact on accreditation. We will have to change the accreditation rules. The agencies are very much concerned and working around this. They're starting to use a different technology. We will switch from the term competency to capabilities. So it's not a matter of doing what you have to do and doing it right, but you need to have the capability to adapt yourself. Probably that adaptation is not that important, considering the number of hours that you need to complete. But more important is that you show me that you are competent and that you can do what you have to do. Finally, I have included a point that I deem very important, and I'm referring to research. I think that research is something that we are losing in a general way because we are so much worried about addressing what is happening on a day-to-day basis. If you realize how much time has gone by after the pandemic started, it's more than 6 months. But all of this that is being used and that is being improvised is something that we need to place within the format of a research. There's no doubt that we have been forced, we have been obliged to live within an experiment that was unexpected and that was under control, that was not under control. We are facing a situation that was not predicted. But this has become an excellent sample to see how the medical schools are handling creativity, flexibility, and they are trying to be assertive. Dr. Limon said that we need to be paying attention to the professors, to the students, or we need to create communities, as Dr. Desai said. Otherwise, we will not be able to move ahead. I think these are the 3 words that summarize very well what we have to do. Now that we are addressing medical education, I know, but this is questioning something that goes beyond medical education. I'm referring to a transformation within the field of education, particularly regarding small children. They have stayed at home for many, many months. And we have stayed at home with our children, trying to educate them with the closing not only of our medical schools, but all of the schools at all levels. This takes us to a critical point that leads us to an interesting point. We have to see how schools of medicine that are not as lucky as yours have had to face the challenge of technology. From the standpoint of the digital divide, we know that there are huge differences in education. Dr. Jimenez mentioned the big effort that is being done at medical schools, trying to provide computers and internet access to the students. Medical schools are negotiating even with internet companies. This is being done by medical schools throughout Latin America, and this is very important. We need to provide access to technology and provide the equipment that students don't have. This is the big difference between equality and equity. It can be equal for all. We need to try to achieve equity so that we can provide to each what they need the most. This is what I wanted to emphasize. I believe equity issues are extremely important. We need to continue to think on them, even if we are doing quite well in different areas. And finally, this has to do with the last question that was asked. I'm really grateful for having participated as a moderator. I participated as an observer in hundreds of meetings during the pandemic. And this has been an incredible experience. Let me tell you something about Mexico, because we are in Mexico. There were professors who told me that not only did they provide clinical teaching, clinical education, but in the middle of the pandemic, they had to convert from on-site classes to virtual classes. None of them had ever used technology, and they were at home, a crowded home with the entire family there with a lot of noise. They had to wake up at 4 a.m. to record their video without any noise. This is anecdotal, but at the same time is very revealing and very important. We are working on this. There are no magic solutions. Each one of us is trying to address their problems as we can. This is from a US paper. It shows that we need to consider that many of the professors in many countries are part of the risk groups because of their age. And if the pandemic comes back, we have a second peak. We don't know how we're going to address this, not only at medical schools and at universities, but also at the regular schools. I'm grateful to Dr. Jimenez because he has set on the table the fact that we are providing the guidelines so that to show how is it that undergraduate and graduate students can go back to non-COVID services. This is endorsed by the health authorities and by the governments of the region. I believe that this is an extremely important point. This is an example to follow. I included this slide because there's something that we are looking at, which is that medical schools that have a lot of media, that are universities with a lot of resources, well, this is becoming much easier for them to adapt than others who do not have all the resources. But we should not forget our students and our professors, because what is coming is what is known as the new normal. But in reality, we don't exactly know what are the components that it consists of. This is a paper by Berwick published recently in JAMA. He reports the things that are happening not only in our setting, but also under the new normal, both within healthcare services and in the society at large. What I'm showing here has to do with the topics that you have also addressed, not only from the world of observation, which is mine, but also from the perspective of what you experience on a daily basis, and from the safety perspective. We could add many more data on how Amnesty International is making a call and is asking us to focus on the death of healthcare workers, and this includes medical students. This is a piece of information that is food for thought. In the first seminar of this series, Dr. Borden of the World Federation of Medical Education, he launched a very clear call that may be interpreted in different ways depending on where we are. His idea, which is endorsed by the World Federation of Medical Education, is that medical students are essential staff and they are first-class workers. This is something which is difficult, and there are many medical schools that are not willing to accept clearly. But I think that all of us need to continue working to see what is the situation at each of the settings where we practice. This is another paper published recently in JAMA. It refers to different measures that have been taken, and you have addressed it differently. It is being suggested by many that we have gone from theoretical subjects of the later years. They are being delivered on-site at the universities. But so that things have changed so that in the second and third year, you will only get theoretical subjects. And all of the clinical subjects will be delivered in the last years, in the fifth and sixth year. This is being done by several medical schools. But if the pandemic is prolonged, you will have 2 or 3 generations of students who will have to go their clinical education, all of them at the same time. We don't know how we're going to solve this problem. But anyhow, telemedicine and telehealth may provide us with many solutions. I would like to say that all of us are also reaching a burnout situation because we have been articulators, facilitators, we have been catalyzers, and have accompanied others. But we need to remember that there is no magic solution, neither for this topic nor for other topics that are being addressed at other webinars and in the coming webinars. But we need to continue to discuss on a daily basis, because the truth of today is something that will not be useful tomorrow or the coming year. It's really difficult to make prediction, particularly on the future, because this is something that I have missed in many of the presentations that I have attended. And I apologize for this, because this is my call to the students who are listening to us. People who are listening, because I think that we need to work even harder in general than what we are doing, so that we do things not for you, but with you. There has come a time in which it is very important to have the students participating in the measures that we take in the future, particularly because they are the ones who will experience this and will experience the impact of this. They are the ones that will provide us with greater creativity than the one that we may have. We have been working with ALAFEM, with the fourth generation, with WONCA, about what are the common points that are being seen in the Americas region, but we are comparing this with what is going on in Africa or Asia. I had a rather long list that has already been mentioned, but has 2 things that I highlighted in red that continue to be the critical points. Number 1, no one knows how we're going to address in the future the clinical practice. And second, the education-related research. And allow me to close by making a final point. Only a few weeks back, this paper was published, and it really struck me.
Asistiendo a una auténtica pandemia.
It says that we are attending a pandemic of publications about education. I know that a lot of our staff, of our team members, are not working on clinical activities. So they are working on publishing things about education. The authors of this paper, that's why I'm showing you the title, they say that most of the documents or the manuscripts that they are getting about medical education and COVID, they are probably not trying to answer the true key questions at this moment, now that we are speaking about medical education and undergraduate and graduate students. This is a paper that is available through the internet. Here they propose the 6 potential scholarship questions for a pandemic. They speak about a guide about the future of research on medical education that we are conducting on COVID. This is a very important point because even though we are improvising now, in looking at the future, we need to make use of the evidence that we are collecting so that we can make sure that we know what are the things that work the best. So this is a very important document. And to close, something that I have deep in my heart with me. These are things that have to do with transformation of education for undergraduates. They also speak about the role of primary healthcare and universal access. From PAHO, this was launched last year by Mexico. A 30-30-30 pact was launched for universal health apps. I think that COVID is leading us to ask what is the social mission of medical education, and particularly we know that COVID has shown us clearly that hospitals play a role. However, public health, community health, and primary health care represent the basis of healthcare system. So what is the role that they should play within medical education? With this, I would also like to thank all of you, of the audience, for their attention. Thank you so much. Thank you for participating in this meeting. I want to thank the panelists because from the comments that we have received in the chat, many people are very grateful. They have said that this has been a very interesting meeting. And of course, I would like to thank UNAM, UDUAL, and ALAFEM for this great opportunity. Let me give back the floor to the organizers. Dr. Garcia, do you allow me a couple of seconds? Yes. There's something that you have said which is of vital importance. Even Spain, during this second peak, the students who are under clinical education continue to be at hospitals. This is because we have a state council of medical students that is working together with the Universities Commission of Spain and with our legal commission. The vision of the students has been vital to change the awareness of the ministry and the Spanish communities to make sure that the students go back to the hospitals and they are not kept outside of their hospitals. The fact that the students are part of this and they participate in each of the decisions has been essential. Thank you for this opportunity. Thank you so much. We want to thank our moderator, Dr. Francisco Garcia, and our speakers. We are very grateful to you for participating on behalf of the Union of Latin American and Caribbean Universities, of the Associations of Latin American Caribbean Schools of Medicine, and of UNAM School of Medicine. Thank you, Dr. Limon. Thank you, Dr. Jimenez. Thank you, Dr. Desai. And thanks to our moderator as well. On the screen, we have a poster advertising our next session 1 week from now on September 29th, same time. We're going to discuss a very interesting topic. During this session, the participants shared various experiences. We've heard from people who are in charge of medical education, undergraduate and postgraduate medical education. This has opened up our vision for those of us who are dedicated to medical education. And this is the purpose of these experiences, to do benchmarking, because it is very difficult to learn from a single experience. It's much, much better to listen to various experiences to see which of them are locally useful precisely at the site where we are working in the country where we live. The next meeting.
Los modelos híbridos, estos modelos que se están generando, que gracias a la
pandemia. We will speak about it on the next session. We're going to address the different models that have been triggered by the pandemic. I'm sure that in the next session, what you will hear about this will be very interesting to all of you working in the field of medical education and medical sciences. We are all sharing the common space of education in Latin America. We have CECELI, which is what UDUAL has made available for higher education. This is the tool that we use to share experiences. Thank you, Dr. Garcia, for being our moderator today. On behalf of the organizers, we thank our speakers. See you next week. Thank you.
Gracias a todos.
Hasta luego, que estén bien.
Venga.